All right, everyone. Hi, I'm Melissa Wilson, host of From the Clinic to the Living Room. Tonight, we have a very special guest for our programming. Her name is Yemi Sucumbi. She is a board-certified both dermatopathologist and dermatologist. She's a consultant at the Mayo Clinic, associate professor of dermatology and laboratory medicine and pathology at the Mayo Clinic's Alex School of Medicine, and also is very involved in the American Society for Dermatopathology. So, Yemi, it's very, very wonderful to have you here tonight. And I'm hoping that we're able to teach everyone how important dermatopathologists are in melanoma.
Well, thank you so much for having me, Melissa. I think it's a wonderful opportunity to educate your audience about melanoma, but perhaps even in this particular scenario, the role we as dermatopathologists play in the diagnosis of malignant melanoma.
And it's an extremely important role for sure. And so I just want to kind of start out with asking, who is a dermatopathologist and how are you trained differently than a regular dermatologist or pathologist? Sorry.
I think to explain that, the starting point is probably to talk about who a pathologist is. So a pathologist is a physician that works to diagnose disease. So diseases in any tissue type. And then when you have a dermatopathologist, you have a physician who might either be a board-certified dermatologist, that's a 3-year residency, or a board-certified pathology, that's a 4-year residency, who then chooses to spend an additional 1 or 2 years focusing specifically on diagnosis of skin diseases. That individual has spent time learning only skin disease and the diagnosis of skin disease. So they develop a significant amount of expertise in recognizing skin disease. And I always say to folks, they become the doctor of the dermatologist. So they help the dermatologist in taking care of their patients.
That's so it's a specialty of a specialty, which is
correct.
Amazing.
Yes.
So now that you've kind of explain the difference between a dermatopathologist and a regular pathologist, how is this different from a dermatologist, I guess, for our viewers?
So I'm a dermatologist. So a dermatologist spends those 3 years recognizing skin disease, meaning on physical examination. So that's the individual you go to see if you have acne. It's the individual you have a rash, you have a change in mole. We'll talk about that with melanoma. That person is the one who assesses you, renders a diagnosis, sometimes not so easy based on physical examination, and then decides you need a biopsy, performs the biopsy, and wisely knows that that pathology or the biopsy needs to be evaluated by a dermatopathologist.
Okay. And really, so this is, especially in this relationship in both melanoma and, in dermatologic diagnoses, really this dermatologist, dermatopathologist relationship is extremely, intertwined. It's a great multidisciplinary relationship.
For the audience, many takeaway points we're going to hear today, but there is an important takeaway, is that the key to a good dermatopathologist rendering a good diagnosis, a reasonable diagnosis, is a wonderful partnership with the clinician or the dermatologist on the back end. That partnership is critical because when we sign out cases in dermatopathology, we rely on the clinical information provided.
Sure.
We rely on the clinician to tell us what they saw. Is this biopsy an accurate size? What did it look like? What was the color? What's the story? So that partnership is critical because it allows the dermatopathologist to really function well and perform our ability at the very highest level.
So dermatopathologists are extremely important across all aspects, but how can a dermatopathologist be beneficial specifically at the diagnosis of melanoma?
So malignant melanoma, as you all know, an unfortunate skin disease. It's the 3rd most common skin disease. It's the most deadliest of our skin cancers. And before you get the diagnosis of melanoma, you need that pathology report. So let's take a few steps back. So the dermatologist sees you in clinic, finds a mole, the mole's changing, it's funny looking, the dermatologist chooses to take a sample. That sample goes over to the lab, it's processed in the lab, a slide is produced for a pathologist to read. Hopefully it is a dermatopathologist. I'll even push it up further, a board certified dermatopathologist. So what that means is after the training, we're taking additional tests, we're challenging ourselves, we're learning more to be at the very top of our game. We have societies like the American Society of Dermatopathology, where it keeps us sort of in tune and up to date with what's new in our specialty. So we get familiar. It's the rule of the more you see, the more you know. So we do this day in, day out. And so we get really comfortable with making a diagnosis of melanoma. And for the audience, the reason why that's important is, as you'll probably touch on, Melissa, the details. It's all the devil's in the details. And that's important for the audience in terms of what treatments do I need? Do I need surgery? Do I need lymph nodes? All of that's based off of that pathology report. So it's the directive, if you will, for the doctor on the bedside, the dermatologist, to act upon to treat the patient.
Exactly. And I know that now, and we'll talk about this in a minute, but I know now there are almost guidelines that the AJCC in the 8th edition is sort of set up. Like, these are the things that you really need to have in a pathology report. So we'll talk about that, viewers, don't worry. But so how do you know that your pathology report was actually signed out by a dermatopathologist versus a standard pathology?
So usually at the bottom of that pathology report, when you have the paragraph, you have the synoptic, we'll get to that. At the bottom, we have to put our names on it. And then usually, I sign it, Dr. Yemi Sekumbi, and then at the bottom, it says board certified dermatopathologist. Okay. So that is really letting you know what I'm coming to the table with in terms of rendering the diagnosis. We also have a very active group, like I said, the American Society of Dermatopathology. It's nice for patients to sort of go to that website, learn who we are. And so then you can come from a position of information when decisions are being made about your care.
Okay, that's super helpful information. So let's get down to the nitty and gritty of now we know who a dermatopathologist is. And now I want our viewers to kind of get an experience of what does this pathology report actually mean? So let's start superficially, because I know we'll talk about the details, but what determines the stage of a melanoma on the pathology report? Like, what things are you looking for staging purposes?
And so it all starts with how deep is it? And so, for the audience here, when your dermatologist does a biopsy, they can either do a shave biopsy where you take a blade to remove the lesion, or they can do a punch biopsy where they sort of drill down, and that tends to go a little bit deeper. The technique of the biopsy, of course, matters. That decision is made based on the type of lesion. So we can be prescriptive. We have to let the provider at the bedside make that decision. But the reason why that decision is very important is malignant melanoma, when we look at it under the microscope, it can be in the first layer of the skin. We call that first layer the epidermis. If it's just in the first layer of the skin, wonderful news. It's the best kind you'd want to have. That's called malignant melanoma in situ. That's the very earliest stage. And then, of course, if it were to go deeper, now we're dealing with what we would now refer to as invasive malignant melanoma. Invasive just means it's broken that first layer, it got sneaky on us, and now it's in that second layer, which is the dermis. And so, Melissa, going to your point as to how we decide the stage, that depth is what really gets things going for just making some of the decisions that will have to be made. And that's used by a micrometer. So we have a ruler within our ocular in a microscope. So you look in the microscope, but there's a ruler in one of my eyepieces. And what we do is measure from the very top of the epidermis, so from the top layer of the skin, to the deepest portion of the malignant melanoma. And that gives us a term called the Breslow's depth. And that Breslow's depth is the first that we use in what we call the T classification of malignant melanoma. If the biopsy is cut off, that happens, right? The technique is done, so it's transected at the base. So meaning, yikes, I can't really tell how deep it is. Then you might hear, or you might see us use a term, at least. Least. So that means we're saying, boy, it could be deeper, but the best I can see on this mic at this time is this depth.
Right. So just a reminder for our viewers, it's an actual measurement. So you're taking the physical measurement. Yes. Sometimes people will see Clark's level on a pathology report, which we know isn't quite as accurate as an actual measurement. And so really, I feel like Clark level isn't really used so much anymore. We're really looking for that Breslow depth. So I always tell patients, look for that on your pathology report first.
Yes.
And that's assuming obviously that you're getting a path report that is a biopsy of an initial lesion.
Correct.
Other pathology reports might include things about lymph nodes and stuff like that. But really in this setting, we're really just looking at primary biopsy diagnosis.
That is, you nailed it. The Clark's level sort of hung around. It's an old friend. I still put it on my report, but you're exactly right. The Breslow's depths, what really matters. The Clark's level is just the anatomic location. So Clark's level 1 is in situ. Level 2 is in that superficial layer of the dermis. Level 3 is it fails that superficial layer of the dermis. Level 4, it's in what we call the deeper dermis, called the reticular dermis. And level 5 is the fat. But the Breslow's depth is what your eyes should hone in on, not so much the Clark's level. And you mentioned it also depends. Is this the primary lesion, so meaning the primary tumor, or is this the wide excision? Is this the cutout from the melanoma, like you mentioned with lymph nodes?
Okay. Perfect. So basically what we're going to be talking about for the rest of the characteristics of the pathology report, just so our viewers know, is like really a primary biopsy, just so that we're clear with our viewers. But so what other so we know Breslow depth is obviously one of the most important aspects of the pathology report. What other characteristics of melanoma from the pathology report help to determine like staging and prognosis?
And so another important one, ulceration. Ulceration is a biggie. In fact, with the AJCC 8th edition of malignant melanoma, a patient gets from that, if you're thinking about early melanoma, a patient can go from a T1A to a T1B if they're less than 0.8 millimeters. As soon as they have ulceration, they're already a B. That's how important it is. And so a melanoma could be 0.3 millimeters. If it's ulcerated, it's already a B. So ulceration is super important. Breslow depth, ulceration, and ulceration usually, we're looking, there's usually an inflammatory response beneath the ulcer. Ulceration tends to portend a higher stage disease, and we see that as we go through the entire Breslow depth classification and T classification, that with an ulcer, a patient gets to a B, T4B, 33B. All of the Bs mean there is an ulcer.
Okay, so that's important to know. So when you see B on your report with your tumor, that means it's ulcerated. That's something that I get a lot of questions about on the Ask an Expert line. So that's very good clarification. What about regression?
Yes. And so regression is the concept by which this melanoma was there, and now you usually see like a scar behind. The challenge with regression is it leaves you guessing as to how deep was this? Is this mostly gone? What was there? And the unfortunate thing, the challenge also with regression is that we know that it tends to be a poor prognostic indicator. It's not recognized in the staging, which means it doesn't affect our TNM staging. It doesn't affect where you do the clinical stage or the pathologic stage of melanoma, but the physicians who take care of melanoma patients, it's helpful to have it in the report because it tells them something about perhaps the prognosis of that patient's melanoma.
Right. So from like a clinical standpoint, like when we see regression, we think, this tumor could have potentially be a little more aggressive because, like you said, we don't know the whole depth. Sometimes regressed tumors have been there for a long time, so we don't know whether or not they've had the ability to metastasize to the lymphatics or other places. So you're right. Like, even though it's not part of staging, we definitely use that in decision making. If somebody's sort of on the borderline of needing a lymph node biopsy or not, sometimes regression sort of pushes our decision into yes, they do, if they're kind of not quite there in terms of depth. How about mitotic rate? I'm just kind of going down all the things that I see in the Synoptic so that we get a better idea of what these things actually are.
I love it. And so you made a very important point that I hope the audience really picked up on, because, when we talked about Breslow and ulceration, I talked about how they impact the staging. But a lot of the things that we have in the synoptic don't necessarily impact the staging, but boy, do they impact clinical decision
Yes.
making.
Mhm.
And so those are the things that impact what people recommend that you get. So mitotic rate, also one that we pay attention to in the previous AJCC staging. Mitotic rate was actually important in staging, not anymore. So
Sure.
mitotic rate right now, we report it in the synoptic, but has no impact on the staging, but it tells a story. It tells a story that you have a tumor which is maybe growing rapidly, which is maybe a little bit aggressive, kind of gets you a little more anxious. Might be one that you might talk about a lymph node a little bit earlier than you would, even though it's not part of the staging. It tells its own story that the physician on the end of that report, or the provider on the end of that report, should pay attention to as they make decision plans for that patient. How do we make that? We report it per millimeter squared is how it's reported.
Yeah.
And so it's usually like less than 1 or greater than 1, but usually we just do what we call a hotspot method. We find a really active area, and then you find like a squared millimeter of the area to report. So you say two mitosis per millimeter squared, 3 per millimeter squared. So that's just that counting that we do.
Okay, so when you're looking at mitoses, and I get this question a lot just in clinical practice, like what is considered bad, or what would you consider to be not necessarily bad, but like a lot of mitoses?
Yeah, so there is no top number. There is no very bad or very, when we had the 7th AJCC staging, as long as you had like greater than 1 per millimeter squared,
Right.
you were already bad.
That was no good, right?
You didn't have to be 100 to be bad.
Right.
But once again, for me as a dermatopathologist, when I'm examining a tumor and I go, oh my word, this is just chock full of mitosis, right? I report it. In my mind, sometimes when I'm calling my clinician to give the report, I'm saying, yes, this looks like a bad tumor. This is very mitotically active. So that's that communication we can share with one another. And so the more mitotically active a lesion is, the more worrisome it is. So there is no top number. There is no cutoff of good
It's
versus
not like
bad. If you're greater than what? Correct.
Okay, that makes total sense. But that's helpful for our patients because sometimes they'll look at their pathology report and be like, I only have 2, so that's probably okay. Yeah. Okay, so the next thing that we typically see on pathology reports are things like intravascular or lymphatic invasion. So what does that mean?
So that's sneaky stuff. So that's letting you know that the melanoma is now in blood vessels or lymphatic vessels. And so once again, is that sticky? It's not part of that T and M, right? It's not part of what we put in the staging, but tremendously helpful information. Why? Because when you get that primary biopsy and you're given the T classification, or you're saying, is this T1A or T1B? Even though lymphovascular invasion does not impact that, it tells a story that you have melanoma that is in the blood vessels, and makes sense that it would suggest that that melanoma may be on its way somewhere else.
Right.
Okay.
Not only for local reoccurrence, but also
Correct.
Distant or regional
Metastasis,
reoccurrence.
correct. You're like, okay, is this going to go to the node? Maybe this person for sure needs a sentinel lymph node, more likely to have not skin disease, but more than skin disease. And so that's a clue that this might be a more serious problem.
Okay, that's really good information. And then the next part is neurotropism. And I will openly admit that in 17 years of practice, it wasn't until about a few years ago that I actually understood what this was. So if it confuses me, I'm sure it confuses everyone else.
You know what? Sometimes we have things on our report, and for the most part, a lot of melanomas are not neurotropy. So for the audience, it just means that the melanoma is making friends with nerves, okay? Nerves that we see in the skin. And, there are some melanomas, I know we didn't really talk about the histologic subtype, but, melanoma, the most common subtype is called the superficial spreading melanoma. You might see that in your path report. You have the nodular melanoma. You have lentigo maligna melanoma. You have acrolentiginous melanoma. There's an unusual, not so common type of melanoma called desmoplastic melanoma. Mm-hmm. That melanoma is notorious for making friends with nerves. And so once again, it's like when we look under the microscope, we see the melanoma surrounding the nerves. And it's also just like the lymphovascular invasion. When the melanoma is making friends with folks outside of the skin, more reasons to worry.
Sure. Now, so would desmoplastic melanoma, just for our viewers, because recently we've had a lot of questions about desmoplastic melanomas, and sorry, we kind of are taking a little turn, but if you have the presence of neurotropism, does that make it more likely to be a desmoplastic melanoma?
No, so that's a very good question. To answer that question, one of the important things to state is when we look through those histologic subtypes of melanoma, goes back to the dermatopathologist based on experience, dermatopathologists, so in our specialty, recognizing what each of these look like. So superficial spreading melanoma, the melanoma cells often look very nested. So sometimes they're like little balls of melanoma cells. They're atypical, but they'll go all crazy within the epidermis. We call that pagetoid spread. They'll make friends with one another. We call that confluence. Nodular melanoma, like the name suggests, would be like a ball of melanoma. Lentigo maligna will be like a radial long phase of melanoma, so just going through the epidermis. And then the desmoplastic melanoma, to answer your question, Melissa, it has a lot of desmoplasia. So desmoplasia means a lot of like fibrous type tissue. So it looks very spindled sometimes and very busy and like a scar-like appearance. And in fact, one of the most common reasons to miss a desmoplastic melanoma is they can mimic a scar.
Ooh, okay.
Yes. And so it looks very different than the other subtypes of melanoma. And so the perineural invasion is not what makes it a desmoplastic melanoma. It's the type, the pattern and the type of cells in that tumor.
Okay. See, that's super helpful, I think, for patients to understand that that's different from each other. So thank you.
Yes.
Okay, so now the things that are a little bit more confusing, but how about host response? So this might also be reported, I believe, as TIL or tumor infiltrating lymphocytes.
Yes, so tumor infiltrating lymphocytes are an inflammatory response to the melanoma. I call it as your body just getting ready to go to war on your behalf. It's what you want to see. We can report it as brisk, a lot, or non-brisk. So we can say present, brisk, or non-brisk, or we say absent. We do know that patients who have a lot of TILs tends to portend a favorable prognosis.
Yeah, so this is one instance where you want to have a good host response.
Yes.
That's right. Yes. Okay, we're almost there. So now there is microsatellites. And so this I would feel like has a lot to do with staging because the presence or absence of microsatellites is important.
Very, very, very important. So remember, I talked about Breslow, I talked about ulcer in the T classification. That's usually more important for like the stage 1, stage 2 melanoma. Microsatellites with the AJCC 8th edition, microsatellites impact nodal status. Super important. It's when your melanoma makes friends a little bit away to the side or deep to the primary melanoma. So the melanoma is right here. When we look under the microscope, it made friends a little bit away. Clinically, you can see satellite lesions. So you have a melanoma spot here. If there's another sort of melanoma lesion less than 2 centimeters away, we'll use the term satellite. If it's greater than 2 centimeters in general, we use the term in transit metastases. All of those things, the microsatellite, the satellite lesion, the in transit met, all impact nodal status, which of course impact upstage in a patient.
The overall stage, right?
Correct.
And I think you made a really good distinction that the presence of having a friend nearby is absolutely is determined by the distance from the primary. So, that delineation of and having that dermatopathologist specially look at your path is so important to really be able to break down that extra step.
Correct. And it's a friend nearby with even more important normal skin between friends. So you go, you're here.
How'd that get there?
Yes.
Right.
Yeah.
So I guess one of the biggest or one of the big overall pictures is that when you're really looking at your dermatopathology report or pathology report in general, you really want to have all of these components as part of what's the bigger picture called the synoptic. So you had kind of touched on this earlier. I wish that we were able to show you a pathology report in total, but for HIPAA and making sure that everyone's privacy is saved, we can't really do that. But usually you have a final diagnosis, you see the actual diagnostic rendering. and then a more microscopic description of what the cells look like. And I always try to tell patients, like, that's a lot of medical terminology that we don't really need to, as patients delve into to know. But this really nice thing is this synoptic part, which gives you all of the components of what your melanoma diagnosis that we just went over, the histologic subtype, the Breslow depth, ulceration, regression, mitoses, et cetera, and it gives that, or should now give all of those synoptics or a summary of what the characteristics of your melanoma look like, right?
That is exactly right. So the microscopic is sort of doctor speak, so that if another pathologist looked at my slide, another dermatopathologist, they'll go, okay, that's what Dr. Sukumbi saw. And then there is the bottom line diagnosis, the first thing you see in the report, usually in bold, and then the synoptic. The synoptic is intended to really make it easier for the patient,
and the clinician,
the busy clinician to sort through the high notes, the highlights, all of the things that are there, impact clinical decision making, but easy to find and all important in guiding next steps.
That's perfect. So I know that, we don't have really questions I think everyone is just enraptured with learning all about the pathology report, but, and also I feel like I'm asking a ton of questions, so I apologize, but
this is wonderful. This is wonderful.
But I think, like, one of the things that I'm sure will come up is, what if a dermatopathologist didn't look at my pathology report? Should I be panicking and try to find someone to do this? Or, what should I do if, when I look at the signature on my path report, it doesn't say board certified dermatopathologist?
Very hard to be prescriptive.
Yeah.
Very, very hard to be prescriptive. I do know that there is significant value in having a dermatopathologist. I mentioned this earlier, as you'd mentioned when you introduced me, I'm part of the American Society of Dermatopathology. And the wonderful thing about this is that we're continuing to learn about melanoma. We keep evolving. And so having folks who do this all the time gather to talk about doing it all the time, to see how we can learn to do it better all the time, just as you can imagine, naturally makes us the easier choice, to be honest, in recognizing. And even more importantly, at our meetings, we're talking about difficult cases. A lot of dermatopathologists like to share cases, something called consensus, because not all cases are easy. Some are difficult cases and some are head scratchers. So I will say to your audience that it's hard to be prescriptive. One size does not fit all, but certainly if you have questions or concerns about your melanoma diagnosis, it would be appropriate to have your slides reviewed by a board certified dermatopathologist.
Okay. And the clinical team, that takes care of you can absolutely help set that up or get you resources about how, that can be done as a second opinion and things like that. So
correct. Your clinical team, your dermatologist, any of the providers are your advocates. And so they're the ones who can help make sure that if that is something you're interested in, there are many of us in dermatopathology that do a lot of second opinion work.
That's amazing. So, Yemi, I have absolutely enjoyed this webinar. I've learned things. I think that this has been a wonderful way to kind of enlighten folks, not only into the world of dermatopathology, but also really I think that has been a really great explanation of what are the important parts of a pathology report. So I think this has been a wonderful service that you've provided us for the last half an hour. And I thank you so much for coming to do this with us.
Well, you're very welcome. Thank you for the platform. I think that I speak on behalf of myself, other dermatopathologists that do this work. We're doing it really for the love of the patient. So your audience, we really want to put our best foot forward to make sure that we're diagnosing skin cancers appropriately so that all patients can receive the appropriate care and management needed.
I appreciate that. I do have one question that came through, and I hope that I can squeeze it in really fast. Yeah. Linda actually asked about patch testing. Like, is that something that, so like there are these skin tapes that are now being used as like initial testing.
Correct.
But if my understanding is that even though that can say this lesion is worrisome or, is melanoma, really, you still have to do the biopsy ultimately.
Yes. So Linda, I cannot overemphasize that technology will continue to move forward, but at current state, the gold standard always at this point to diagnosing a malignant melanoma is by tissue sampling, so by a biopsy that needs to be read by a dermatopathologist to give that pathology report we've been talking about. You'll get none of that from that tape. So I would not recommend that as the way to go at all for a melanoma diagnosis.
Perfect. See, I felt like that was an important enough question that we had to squeeze it in at the end.
Very important. I started, the sample tissue is the issue. The sample matters. Yes.
Exactly right. Well, Yemi, it's been wonderful. I appreciate you coming on. Hopefully we can talk again in the future, but on behalf of AIM, thank you so much for joining us tonight.
Thank you for having me.
We'll see you next time.
All right. Good night.
Good night.